Hi all, welcome to RAAONLINE. Today we will be dealing with how to plan your anesthesia. What are the various things you do in the preoperative period and how you plan your anesthesia. The first important thing which you see in the preoperative period is how long the patient has to fast. Then the most important planning comes for the pain management, particularly in the postoperative period. Then in the intraoperative period, you have to plan various things according to the guidelines issued by various bodies which might have regulatory issues. Then comes the pre-evaluation clinic, whether the clinic is led by the anesthesiologist or the primary physician, and who are the patients who require pre-op consultation for optimizing the patient. Finally, in the preoperative period, before planning anesthesia, the surgeon, the physician, the anesthesiologist all should function as an integrated unit. Now coming to the fasting. The goal of preoperating fasting is to reduce the risk of pulmonary aspiration. That is the most important priority. This becomes very important when you handle a difficult airway scenario. Before you secure the airway, the patient might aspirate, so it becomes more important in a difficult airway scenario. And the type of fluid taken is more important than the amount of fluid which is ingested. The factors which increases the risk of aspiration includes gastrointestinal motility disorder, diabetes and autonomic neuropathies. Coming to the published guidelines for fasting, clear fluid for all patients, there should be a minimum fasting for at least 2 hours. That is minimum fasting status. For neonates and infants, it is 4 hours following breast milk and 6 hours following formula, non-human milk and solid. For other patients than infant, there should be a fasting of 6 hours after a light meal, and this period is increased to almost 8 hours if the meal includes fried or fatty foods. Now coming to the pain management. Your pre-op evaluation should be done in a such way you have a baseline pain assessment, how the patient will react to pain. That is very important. But standardization of pain measurement is difficult. Therefore, you have to incorporate pain measurement scales into picture. And there are multi-dimensional scales and single-dimensional scales. Single-dimensional scale include your visual analog scale and numeric rating scale. In numeric, you will put a number from 1 to 10 and ask the patient what number he belongs to the pain, where 1 is low pain and 10 is the severe pain. Multi-dimensional scales include McGill pain questionnaire and modified brief pain inventory in the short form. Although multi-dimensional scales are longer, they capture a broader range of important detail. For example, in the 9-item modified brief pain inventory, it captures pain intensity, how severe is the pain, where is the pain located, and if the analgesic treatment is adequate or not, and how does pain interfere with your regular activity. So many things are taken in this multidimensional scales. Consistent use of the same scale during the perioperative period allows comparison when the reassessment are performed after surgery. So, if you use one scale in the intraoperative period, the same scale should be used in the postoperative period. That is very important.